Welcome to The Explainer. Today, we're taking a deep dive into an organism that, every single microbiologist knows, but its clinical significance, well, that's often really underestimated. We're talking about Micrococcus luteus. It's a bacterium that's so often just written off as a simple skin contaminant. But as we're about to see, it can be a really formidable pathogen in the right host.
Okay, so here's how we're going to tackle this. We're going to follow a classic bench-to-bedside path. We'll start with its identity, who it is, and its history, then move through all the essential lab diagnostics. From there, we'll look at its real-world clinical impact, especially on vulnerable patients, dig into the major complexities of treatment, and finally talk about your evolving role in managing these infections.
So first things first, let's totally reframe how we think about Micrococcus luteus. It's really time to look beyond its reputation as just another lab contaminant and start to understand its potential as a true pathogen. And this slide really gets to the heart of it, this incredible contrast. I mean, sure, Micrococcus luteus is classified as a risk group 1 agent, but there's a growing mountain of evidence, especially from the last couple of decades, that clearly establishes it as a serious pathogen in the right clinical scenario. Its history is actually pretty rich. I mean, it most famously played this pivotal role in Alexander Fleming's discovery of lysozyme, which is amazing. But that 2003 reclassification, that is absolutely critical. It tells us that modern taxonomy has forced us to go back and seriously reevaluate all that older clinical data and question what we thought we knew about its ability to cause disease. So, if we look at its formal classification, its family tree, it's placed within the high G+C content phylum Actinomycota. And this is a really important distinction because it puts it in a completely different lineage from the staphylococci it's so often compared to on the bench. They're not even close cousins. All right, let's head over to the bench and see how this all builds up. We're going to cover the core characteristics we all rely on for a presumptive identification. These are the classic signs that should make you think, maybe this is Micrococcus. So under the microscope, the absolute textbook feature is that beautiful tetrad arrangement, right? That's a direct result of it dividing in 2 planes. But here's the catch, the key pitfall to always remember. It has this tendency to decolorize in older cultures. It can look gram-variable or even gram-negative, and it can be so easily mistaken for something else. And then on the plate, its most telling feature is that vibrant lemon yellow colony. That pigment is what gives the species its name, Luteus, which is Latin for yellow. You see that, combined with its slower growth rate compared to staph, and those are some really strong clues. And this table just brilliantly lays out the crucial biochemical differences. That positive oxidase test or the microdase test, that is the fundamental differentiator. It separates it from the entire Staphylococcus genus. It's such a simple, rapid test that gives you a clear fork on the road for your identification workflow. Okay, so while all those classic methods are absolutely invaluable for a presumptive ID, let's be real. For any clinically significant isolate, especially one from a sterile site, you need more advanced techniques for a definitive identification. Nowadays, MALDI-TOF is the absolute workhorse, right? It's fast, it's accurate, and it's fantastic at reliably telling Micrococcus apart from its close relatives like Cocuria. But for any case that's still a bit ambiguous, 16S rRNA sequencing is still our gold standard, our ultimate truth teller for confirmation. So this all brings up a really critical question. How does this history of misidentification actually affect our understanding? Well, it means that a lot of those older case reports that attributed severe infections to Micrococcus luteus, they might have actually been caused by Cocuria species. This just muddies the waters of the historical literature and makes modern, accurate identification that much more vital. So when does this organism cross that line? When does it go from being a likely contaminant to a potential pathogen? The answer, it turns out, lies almost entirely with the patient. And here's the bottom line. A significant infection is almost exclusively seen in patients with compromised immune defenses or when there's a foreign body present. We're talking central lines, prosthetic valves. These things provide the absolute perfect nidus, a perfect foothold for this organism to set up shop and cause a real infection. The spectrum of disease it can cause is pretty broad, and it's directly tied to those risk factors we just talked about. Catheter-related bloodstream infections are probably the most common thing we see, but it can also cause incredibly severe deep-seated infections, like endocarditis on prosthetic valves or even meningitis in neurosurgery patients. 2, that's the magic number here. To really differentiate a true infection from simple contamination, the clinical evidence standard is high. Most studies and clinical guidelines require at least 2 consecutive positive blood cultures drawn from separate sites. One positive bottle is just very rarely enough to act on. All right, now we get to what is probably the most significant challenge for both the lab and the clinical team: antimicrobial susceptibility testing and all the treatment decisions that follow. This is really where your expertise becomes absolutely critical. This right here is the central problem. It's what I call the breakpoint void. Neither EUCAST nor CLSI provides official species-specific clinical breakpoints for Micrococcus luteus. And what that means is we can generate an MIC value, sure, but we can't reliably translate it into a clinical interpretation of susceptible, intermediate, or resistant. It's just a data point without any context. Now, one thing we do know for certain is that this organism has a well-characterized intrinsic resistance to macrolides. It's mediated by the M36 gene, and this is a key piece of knowledge to have in your back pocket. It means these drugs should just be avoided in treatment, no matter what an in vitro test might suggest. So, with no specific guidelines, treatment has to be guided by published case reports and expert consensus. Basically, we're playing detective. Vancomycin is the agent that comes up most frequently for severe infections, and it's often combined with rifampin for its excellent biofilm activity in cases of endocarditis. And of course, device removal is almost always necessary. Let's take the Netherlands for an example, where the swab guidelines are standard. Treatment has to be extrapolated by making an analogy. So, for a case of endocarditis caused by a penicillin-susceptible isolate, a clinician might look at the guideline for Verdin's group streptococci and adapt that, which could mean a regimen of high-dose penicillin G. And if you think the data for adults is thin, well, for kids, it's practically non-existent. That makes every single case report incredibly valuable. There's this one critical report from the literature about an infant who failed cephalosporin therapy, but was successfully treated with linezol. This gives us a crucial clinical pearl for those refractory or really severe pediatric infections. All right, let's bring it all home. Let's wrap up with prevention and summarize the key takeaways that really impact your role in the lab and in the hospital. Thankfully, prevention is pretty straightforward. Micrococcus luteus is a normal part of our skin flora, so meticulous hand hygiene and standard infection control precautions are highly effective. It's also easily killed by common hospital disinfectants, so your standard environmental cleaning protocols are totally sufficient. So here's the crucial takeaway from all of this. That breakpoint void fundamentally changes our role. We can't just be reporters of MIC values anymore. We have to become clinical consultants. This means adding interpretive comments to reports, proactively picking up the phone to talk with pharmacy and the infectious disease teams, and providing that vital clinical context that the raw data just can't. All the information in this explainer was sourced using Gemini Deep Search. Now, for a full list of references and to really dive deeper into the primary literature, please check out the linked notebook document. We really value your expertise, so please subscribe to the channel and leave your own clinical pearls and suggestions down in the comments below. Thanks for watching.